Hello everyone, and welcome to this audio podcast and this series wherein there's an RPSG and a KDOS collaborative alongside a Storm Robotics production. This is the Shientist with an audio podcast as part of the series, the Illmatix series. This is an audio podcast looking at renal health, renal health. Renal health in aligned to transfusion research and practice. Before I begin this audio podcast, this works has been put forward for peer review in a scientific put forward in a scientific journal. The works around this originally sort of began in around 2015 or 2016, and there has been a sort of a book publication around this as well, and at the same time work relating to this has been sort of explored through sort of presentations in another format. However, to begin with, or in line to this works, what I thought I'd do is provide an overview, or provide a sort of audio podcast, where the works, where I could provide sort of this works in and around the works that have been put forward for peer review. So to begin with, some introduction, an introduction, or part of the intro. So to begin with, the question is to begin with, to highlight transfusion practices are developing, incorporating many novel pharmacological agents into aspects of healthcare in view of the potential longer sort of term risks and side effects of red blood cell transfusion and red blood cell transfusions. And there is ever more need to consider renal health specifically for patients who require transfusion care, especially since renal function is important in the synthesis of the hormone erythropoietin, and where renal insufficiency is evident, this can be the difference between morbidity and mortality. Although although these risks are generally well reported, although the risks are generally well reported and have led to a sort of re-evaluation of sort of criteria for the use of blood products, or for the use of blood products, a significant proportion of transfusion practitioners apart from where, so for example, apart from just to highlight here, apart from specific areas or specific aspects of transfusion practice, where guidelines and standard operating procedures are followed within transfusion and hematology, in transfusion and hematology laboratories, transfusion practitioners have not modified their approach, and what this contextualizes is healthcare practitioners, or transfusion practitioners, or laboratory specialists sort of rely on guidance, rely on the use of guidelines and following frameworks, which is absolutely appropriate and correct. But at the same time, the transfusion practitioners in amongst transfusion laboratories and in amongst sort of hematology in around hematology practices are sort unfortunately are not always sort of indicative of implementing sort of evidence-based approaches through the use of approaching literature evidence and evidence-based practice in context of literature in and around these practices, at least in and around where, for example, where renal insufficiency where renal insufficiency is not and does not form a basis in and around aspects of transfusion practices, considering renal function and renal anatomy is a basis around for example around hemoglobin, anemia, and red blood cells. Now, with this, although risks are well reported and have led to a sort of re-evaluation of criteria for the use of blood products, a significant proportion of transfusion practitioners have not sort of modified approaches because of fear of the mortality and morbidity related to anemia, especially in what has been documented and evidence listed as untransfusable patients. Now, I'll get into I will highlight a bit about sort of the definitions around untransfusable patients. So especially in untransfusable patients and or patients at risk of developing forthcoming sort of complications. So in line with this, I'm now going to highlight some aspects around chronic kidney disease. So chronic kidney disease is a long-term condition in so much that in works that have been published, chronic kidney disease has been referred to as a long-term condition. In other publications, in other works, it's referred to as a chronic illness. Irrespective, chronic kidney disease is a long-term condition or chronic illness that can be summated as a steady and consistent reduction in renal function over time. Primarily in the disease and development, patients with CKD will have no identifiable symptoms, and this and thus it is largely by and large is in literature has also been referred to as a silent based disease or condition, and this has been the case for many years. And CKD in general population has also been sort of evidenced as underdiagnosed as an underdiagnosed sort of condition. Even in the absence of indicators or symptomology, CKD has significant impact on sort of primary health sort of conditions, and can cause death, morbidity or death, sort of acutely, suddenly, or over time, owing to its clinical manifestations. CKD thus has been increasingly has increasingly been sort of recognized in some regard as a sort of a global public health issue and a sort of a determinant of poor health outcomes. And then there is compelling evidence that disadvantaged communities, for example, those in low resource, racial and minority ethnic communities and/or indigenous and socially disadvantaged backgrounds, suffer from marked increases in the impact of unrecognized and untreated CKD. Although the entire populations of some low and middle income countries could be considered disadvantaged, additional factors create a position of extreme disadvantage for certain population and groups. For example, those living in some rural areas, those who are young, and the females, for example, and also the elderly. Um, and also, just to as another side aspect here, just to sort of reiterate, CKD has also been highlighted in literature as a condition that affects that stems from or is in part with comes with in amongst the elderly or in older age. However, CKD has sort of manifestations wherein, for example, it can affect various age groups, various ethnicities, and also across population health, across population health more generally. And so generally, CKD has no discrimination in relating as a as a as an impact in sort of disease causation. The fact that even in developed countries, CKD has increased, and outcomes suggest that there is much to learn beyond the traditional risk factors contributing to this irreversible condition, and associated and alongside sort of associated complications. So renal function is established by the degree of glomerular filtration rate or estimated glomerular filtration rate, and in this works there is there is a sort of an overview that provides characterization of the different stages, different CKD forms of severity, alongside the sort of classification according to severity by glomerular filtration rate or GFR. Now, in context of health and red cell blood transfusion care, so the ability of red blood cells to facilitate transport of oxygen from the environment to mitochondria has been repeatedly demonstrated in physiology research, and there is a huge and ton of research in relating to mitochondria research in aligned to physiology and other life sciences. The physical characteristics of red cells or red blood cells and properties allow them to allow red cells to increase the solubility of plasma for oxygen by an estimated 30-fold. In addition, the affinity of red blood cells for oxygen is modulated by regional acid-base conditions to favor oxygen loading at the pulmonary alveolar capillary interfaces, as well as unloading at the tissue level. At present, there are no clinically available fluids that have the loading or unloading and carrying sort of properties that are equivalent to that of blood or red, or more specifically erythrocytes or red blood cells. Now, a biomedical or clinical intervention and the decision when to prescribe or administer red blood cell transfusion is not always routine, and having appreciation and knowledge of CKD and or renal insufficiency from an intervention perspective is also important in the management of patients, because renal function has a critical role in the synthesis of red cells through the hormone erythropoietin. While synthesis of EPO may not be compromised in patients with renal insufficiency, and as another side aspect here is to highlight that people can have absolutely devastating renal function, where there can be renal insufficiency, but at the same time there can still be synthesis. There can be some basis of synthesis around the hormone erythropoietin to help stimulate red cells through renal function, even in a sort of in renal reserved sort of function, renal reserve based function, and if there is evidence of reduced estimated glomerular filtration rate leading to CKD, chronic kidney disease, this can potentially affect patients' overall hemoglobin, and hemoglobin, as listeners would hopefully know, that relates to hemoglobin relates and is in regards to signs of anemia. Now, with chronic kidney disease prevalence with CKD prevalence steadily increasing, scientists alongside with clinical teams in hematology and transfusion, and also biochemistry, in and around biochemistry should consider further renal health of all patients with long-term conditions and chronic illnesses where red blood cell transfusion may be warranted in aspects of healthcare, and also aligned to where renal health should be considered aligned to sort of best practices. Now the question this then leads into the question why consider renal health in all patients? And obviously I've sort of answered the question, but to elaborate, this is actually a very important question that all scientists in transfusion should be asking routinely. Considering the renal health and blood physiology of patients who may require red blood cell transfusions in future is a key to considering is a key to achieving best practice more so than ever, not least because CKD prevalence is increasing, but also because transfusing patients with reduced estimated glomerular filtration rate or renal function, or patients with chronic illnesses or long-term conditions can further compromise renal function over time. So I'm just going to highlight this a little bit again, where, for example, irrespective of renal function, where renal function can be normal or abnormal, or where patients with different conditions either way renal function can be compromised, and so with renal function decline, this has an impact on overall treatment and care plans. Now, those care plans on overall treatment and care plans again would be non-specific to renal. For example, if let's say, for example, someone is diagnosed with a form of cancer, or someone is diagnosed with a form of hematological condition, for example. So with renal function decline, this has an impact on overall treatment and care plans, and patients then potentially becoming untransfusable. And so what this means is that the conditions, the health conditions that are, for example, open quote close quote, for example, non-renal if someone is diagnosed with other sort of conditions, generally number one, renal function can be compromised. And then also, in addition, because in transfusion laboratories there's a sort of intense focus, and quite rightly and appropriately, in some regard, where, for example, the focus is primarily on ensuring hemoglobin or anemia is addressed, which is absolutely correct. However, what I'm saying here, or as part of this works, is to highlight that if patients have other health conditions, and for example, or I mean other health conditions that are non-renal, what then happens is, because generally renal insufficiency, where historically is not really has not been a focus in the literature, according in align to other health in align to transfusion based practices. This then means, or this then can mean, that where patients are untransfusable, can be untransfusable, the issue may not be, for example, just around may not be just on the basis of the condition. That might be, for example, hematological or cancer based condition, or another form of condition that compromises in context of being where patients may need red cells, but then at the same time are untransfusable. There is then, in line to this, renal insufficiency or renal function. Or renal insufficiency is generally amongst aspects of scientific practices, are not and have not been a basis around when considering aspects that are aligned that are in regard to untransfusable patients. Now, and following this, there is some data to say that, for example, so full details of sort of the incidences and prevalences in around the different severities and classifications around chronic kidney disease can be identified through for example, the renal registry data, at least from the United Kingdom, and in other parts of the world there would be sort of epidemiological and registry based research data that looks at the incidences and prevalences according to sort of renal insufficiency in those parts of the world, in other parts of the world. That being said, the all-cause mortality rate in CKD is 30 to 60 times higher than in the general population, and scientists and clinical teams now need to question what the clinical implications for transfusing and the decisions needed to transfuse safely, if at all. And so In line with this, I'm now going to highlight some aspects in relating to clinical factors and decisions to transfuse. So the clinical decisions are still challenged or questioned, relating patients' understanding or professionals having the knowledge about management guidelines and personal experiences with transfusion, and attitudes and the beliefs about how to best about how best to manage anemia in patients with a long-term condition or chronic illness. Um, Now, scientists or laboratory specialists implement laboratory techniques, laboratory investigations, um, and especially with regard to, for example, blood grouping and cross matching. And so several authors works have been developed where works has indicated or informed failing tissue oxygen would be ideal to guide the requirement or the need for transfusion, but this modality has not proved effective and reproducible or sensitive to regional tissue hypoxia. Um, and uh, and also the clinical importance of red blood cell storage lesion, for example, the time dependent metabolic, biochemical, and molecular changes that stored cells undergo is still lacking. So red cells can be filtered, washed, frozen, or irradiated for specific indications, and donor screening and testing have dramatically reduced infection risks in the developed world, making transfusion more accessible. But infection can remain a hazard in developing countries, where it has been highlighted in some works that 13 million units of blood can go untested. For example, human immunodeficiency virus, or HIV, or hepatitis virus. And despite serious immunological and non-immunological complications, red blood cell transfusions still hold sort of the therapeutic index that exceed that of pharmacological interventions where red cell replacement is concerned. Now, in and around sort of the guidelines and frameworks, and whilst there is now excuse me, more awareness of chronic kidney disease, again, in some part. And what I mean in some part, I mean as in where CKD in relating to population health, is it relates to where where there's awareness of an awareness of CKD in context of population health, but in line to specific sort of pathology practices, are and sort of strategies for the management of patients with markers of renal disease. CKD or chronic kidney disease is not a condition a condition that is or forms part of transfusion laboratory practices. And with this, scientists sorry with this scientists and transfusion practitioners enhancing sort of skills should look to review guidelines and frameworks and evidence-based works surrounding the literature, updating skills and understanding relating to strategies for renal for transfusion therapy, so that's to become familiar with for example, to become sort of familiar with the sort of definitions of for example renal anemia. In the National Institute of Clinical Excellence, or NICE guidelines, there have been a definition around renal anemia, where using a threshold of 11 grams per deciliter to define anemia, and the need and the requirement for treatment has been or was a sort of a basis around around renal anemia. And in line with this as well, in line with this, reviewing guidelines, although is a good start and recommended to ensure that practices are robust. At the same time, health professionals in line to sort of professional practices or proficiency, for example, should be encouraged, or are encouraged to develop works around transfusion practices, to ensure a continuum around aspects of professional development and proficiency. Now, in line with this, the mean hemoglobin declines. The mean hemoglobin declines as renal function reduces in subsequent stages of CKD, and this is when anemia then catches up with additional clinical symptoms. And it is to be noted that guidelines or guides that have been evidenced and documented can be used for all patients with a long-term condition and or chronic illness. Now, although red blood cell transfusion in the UK is generally safe, is safe and indeed and most and where most serious adverse events originate in, where there's been documented evidence to inform that most of the serious adverse events originate in sort of hospital settings rather than within sort of blood transfusion centers. However, ensuring a safe and effective blood supply remains essential, at least in again where renal insufficiency is concerned, and this requires a combination of high quality donors, where donors are for example willing to donate blood where applicable, and also where infection screening, serological investigations, and blood component production, followed by rational clinical use, is also implemented. Now, the four UK blood services, so the NHS Blood and Transplant, Northern Ireland Blood Transfusion Service, Scottish National Blood Transfusion Service, and Welsh Blood Transfusion Service, all maintain common standards of blood donation, testing, and screening and blood screening in and around blood products. An organisation that's also been been around for some years now, some time now, is referred to as the Joint UK Blood Transfusion Services, and the Joint Professional Advisory Committee are responsible for producing sort of guidelines in and around blood transfusion services in the United Kingdom, and often known as or referred to as the Red Book. Now, the Red Book is also sort of governed, if you like, or the practices within the Red Book are governed, if you like, by the Medicines, Health and Research Authority, or MHRA. And in 2011, the UK Blood Services issued 2.1 million units of red cells, 300,000 platelet doses, 288,000 units of fresh frozen plasma, and 126,000 units of cryoprecipitate. And so this then leads into sort of where I'm going to highlight a little bit around transfusion alternatives. So different transfusion alternatives are known for the pre, intra, and post-operative period. Autologous blood donation and EPO, erythropoietin-based pharmacological stimulating agents, are efficacious in the pre-operative period or duration. Intraoperatively, acute normovolemic hemodilution, cell salvage and antifibrinotics, specific anesthetic and surgical techniques, coagulation monitoring, acceptance of minimal hemoglobin values, and artificial oxygen carriers can reduce the use of allergenic red blood cell transfusions. In the post-operative period, duration, cell salvage, antifibrinotics, and anti-minimal and accepting minimal hemoglobin values generally represent alternatives to red blood cell transfusion. Alternative to red blood cell transfusion also should be given a consideration. Generally, however, at the same time, more focused evaluations or works are needed where specific long-term conditions or chronic illness populations are considered, and transfusion alternative and where transfusion alternatives are required. Works are required to evaluate and clarify the best use of treatment options, considering once again considering renal insufficiency or renal function. Now this works has been put forward for peer review, and within this works there is a sort of there is a basis around sort of a literature review and sort of the analysis of particular literature. And what I'm going to do here is highlight sort of the analysis aspects of the literature, wherein, for example, literature was sort of interrogated where literature retrospectively was interrogated from 1977 up to 2015. So an initial sort of search was conducted, whereby general terminologies have been implemented, and where terminologies were arranged into three main categories. Category 1 was blood and care. Category 2 was renal health and care, and 3 was leadership management and care. And works have highlighted sort of abstracts and articles that establish sort of the literature in around these particular categories. And at the same time, as part of the sort of literature review process, two database search engines were used. One was referred to as one that was used was PubMed, which is common for sort of for scientific based sort of research works. And also EBSCO host database, which is used for sort of research that are related to, for example, population health investigations, and amongst others. Now, the analysis and the synthesis of literature comprised a basis where a critical appraisal skills program was implemented, and using the critical appraisal skills program, papers were initially classified based on study, and so what this meant is where investigations in and around the literature were qualitative, quantitative, systematic reviews, randomized control trials, interventional investigation, cohort studies, case controlled, and diagnostic test investigations or studies. And through this, 450 abstracts went under a sort of 10 question screening process. The appraisal skills program helped analyze according to the following. So number one, is the investigation valid? Number two, what are the results? Number three, will the results help locally? And then amongst others, these were the main critical skills a program critical appraisal skills program questions. So the three main ones, and then there were 7 additional ones. Several prompts are given or were given after each question, and these were designed to remind why the question or the aims or objective around the works were important. Overall, a total of 141 abstracts through PubMed search engine and 196 through EBSCO host databases had been identified, and after removal of duplicates, 274 abstracts were subjected to inclusion and exclusion criteria, and in synthesis of 274 abstracts, 82 papers were further evaluated, which helped to derive themes. The four primary issues were recognized. So number one, there were only 3 papers that explored red blood cell transfusions and considered renal insufficiency before 1978, which comprised a basis around theme 1. Number 2 was the literature managing anemia in chronically ill or untransfusable patient in some contexts where literature has developed around untransfusable patient. There have not been formal care plans to safeguard red cell blood transfusion in different patient populations for the longer term. And this context formed part of theme 2. Number 3, the alternatives and indications for red blood cell transfusion in patients with a long-term condition or chronic illness are still somewhat inconsistent and not transparent universally, and this can make practices difficult to standardize. So that context was in regard to theme 3. And number 4 was there is limited emphasis on the importance of research in leadership and management to inform best practices, which comprised of theme 4. Now, the literature within the works surrounds contextualizes around in and around the different themes, and so I'm going to highlight just the sort of the overall themes. So theme 1, where it was was more specific around the lack of renal health in transfusion care strategies for patients with chronic illnesses, using chronic kidney disease as an example. And theme 2 was surrounding managing anemia in chronically ill or untransfusable patient. And theme 3 was looked at alternatives and indications for red blood cell transfusions. Theme 4 looked at the importance of research in leadership and management to inform best practice. And so around this, I'm now going to highlight some aspects in relating to the discussion in around this works. So this work aimed to number one, understand what further aspects of care are required for patients with long-term conditions and chronic illnesses. Number two, to highlight what specific practices would help in the development of transfusion care guidelines. And three, to provide an understanding of treatment alternatives, taking into consideration renal insufficiency from a leadership management perspective or stance. And in around this also. That it's important that sort of scientists make decisions and interpretations based on requests in front of them, by acknowledging how a clinical team might be caring for a patient in the longer term. However, related to one of the first objectives, scientists should also become more acquainted with clinical and medical parameters of disease to understand what forms of treatment would be best for longer term trajectory and future care plans. And so this means there must be or should be more intricate multidisciplinary team efforts where members of the healthcare team sort of communicate more frequently, and where scientists are also involved in those meetings. And this would help. This would certainly help meet mutual objectives and inform practice. Number two around this was another part of this was, or number two around this was when thinking about what specific practice would help in the development of transfusion care guidelines. It is important to know. What has worked in the past and what hasn't. Transfusion teams nowadays are certainly overworked. Sort of with an aging population, and to an extent there may be more issues honing down specifics on best practice to inform care guidelines, which is absolutely appropriate. But more to the point is that at present there needs to be more investigations in this specialty, so practices become sort of more almost more tailor focused for patients. Another aspect around this is phenotyping. So phenotyping is one way that could help match patients with suspect renal insufficiency. And in the United Kingdom, all National Health Service trusts or hospitals need to integrate aspects of practice as part of a hub-based practice of what works and what doesn't when it comes to transfusion care for patients with long-term conditions and chronic illnesses. And at present, again, departments use standard operating procedures as guides and decision making, and so this then number one can lead aspects of standard operating procedures open to interpretation, and number two, where decisions are made upon the scientist's discretion. And of course, there's absolutely nothing wrong with implementing standard operating procedures. It's absolutely applicable. However, the standard operating procedures more often than not do not factor in renal insufficiency in untransfusable patients, and so this leads into the third part in around this discussion. So to provide an understanding of treatment alternative taking into consideration renal insufficiency from a leadership management stance is generally important. And again, there needs to be more evidence-based practice of what works and what doesn't, and this context needs to be again looked into from sort of integrative an integrative viewpoint, and at the same time it is at the same time, where leadership and management is concerned, scientists also need to be involved in raising awareness and providing sort of education to clinical and medical teams clinical and medical teams of the more intricate aspects around laboratory practice, but also highlight what treatment alternatives there are that will help preserve renal function over time. So it's as if scientists must impart knowledge of transfusion alternatives, this is generally this is sort of rarely implemented, or rarely achieved, and if and only really achievable if there are sort of proactive scientists who know the intricate nature surrounding CKD or renal insufficiency. Transfusion practices are enhancing through service developments in at least through particular guidelines and frameworks. However, consequently, although iron stores, for example, predominantly in physiology, or biochemistry context, ferritin may be normal. The transport of iron either from gastrointestinal tract or iron stores to the bone marrow is and can be inhibited, leading to a state of functional iron deficiency and subsequent anemia. So scientists are in the game of saving and sustaining lives, and they should not be supporting care where lives are potentially where lives are potentially being sort of compromised, and this then leads into the sort of an additional point wherein if scientists or health professionals are not implementing evidence-based practices or are not involved in developing written works or evidence-based works, then that can also compromise healthcare sort of more longitudinally for patients, irrespective again of whether they may have renal insufficiency or not. So in context of further research and interventions, so research and interventions have certainly advanced in supporting patients with long-term conditions and chronic illnesses, especially with regard to ready-to-use protocols such as erythropoietin or EPO, and alternative forms of red blood cell transfusions. There is still quite a gap in research, and this mainly focuses on patient management in the short term. The question again, a question that has been raised is then what should be done better, and in part in some part the question has been answered, but this is a question that can only really be answered by conducting more investigations that compare different forms of treatment alternatives over time, and there is a need to explore supplementation of adjunctive agents such as iron, folic acid, and vitamin B12, and use of EPO substitutes in untransfusable recipients may provide an alternative to red blood cell transfusion or blood products, but obviously in emergency cases, red blood cell transfusion cannot be replaced in terms of volume and replenishment. Everyone knows, or listeners will know generally, I'm sure, that red blood cell transfusion and through red blood cell transfusion, the volume of red cells within a red blood cell transfusion or red blood cell unit of blood is and cannot be replaced in terms of volume and replenishment. And there are several investigations to indicate that use of more stringent triggers for hemoglobin less than 100 grams per liter. However, these do not appear adversely to adversely affect patient outcomes. And at the same time, research seems to continue to neglect renal function when it comes to transfusion guidelines and practices, and this is an ongoing sort of general concern. Feasibility pilot investigations or pilot studies in a group of patients with different long-term conditions, chronic illnesses, who are perhaps prescribed red blood cell transfusion routinely, are required to understand and appreciate whether in the longer term they would benefit or there would be advantage from other forms of replacement treatment options. Further research must also consult renal guidelines. For example, again, as I mentioned previously or earlier, where there's in around epidemiological investigations, population health, the renal guidelines also are in regards to the renal guidelines in regards to the renal registry or the renal association, or what is known now or referred to now as the UK Kidney Kidney Association, or UKKA. Would be sort of the first port of call for scientists who have an intrigue in this area and can help gain more knowledge relating to what formally constitutes chronic kidney disease and renal insufficiency, insofar as much as in regards to transfusion and hematology practices. And so, in conclusion, scientists should not preclude passing on important knowledge of care that might also have an impact on care pathways. In this regard, if transfusion services are to be effective, scientists need to take ownership to ensure safe and quality assured practices, and there is sort of interactivity at various levels, allowing all to sort of voice concerns when required. Having transparency in terminology is also important because this has an impact on knowing the intricacies surrounding renal disease or renal failure more generally. And reflection is paramount to help bridge gaps, integrate renal health and sort of integrate renal health research in the future care of patients with long-term conditions and chronic illnesses. And the works have several references or further reading, if you like, and some of these will be highlighted in the sort of information or descriptive links alongside this audio podcast on in and around social media. And so with that, I end on this audio podcast. This has been an RPSG and KDARS collaborative audio podcast as part of the Illmatix series. This has been an audio podcast surrounding renal health in transfusion research and practice, and it's been this is a Shientist with an RPSG and KDARS collaborative aligned to Storm Robotics production. Thank you for tuning in.